to try to make it clear and easy for the staff to understand which patients need to have people accompanying them in the bathroom.
Welcome to Key into Quality, the Mayo Clinic podcast, where we explore the people, practices, and principles that elevate healthcare quality and safety. Thanks a lot for joining us. I'm Dr. Tim Morgenthaler, Professor of Medicine here at Mayo Clinic and Vice Chair of Mayo Clinic Quality. And in this episode of Key into Quality, we're taking on one of the most persistent and sensitive challenges in hospital care as part of our series on patient falls. This time, we're talking about patient falls and especially focusing on those that tend to occur in the bathroom. Welcome, everybody. So it turns out that a lot of inpatient falls occur in the bathroom. We know that bathrooms are vulnerable spaces. For years, they've often been seen to be the highest risk areas for falls in the hospital, but they're also kind of deeply personal spaces. I mean, I don't want people following me into the bathroom, but they are the places where safety interventions can kind of feel at odds with patient privacy and autonomy. And so, one of the questions that we'll really dig into today is how do we respect both the need to make spaces safe and respect patient privacy? On today's episode, we're highlighting an initiative that's really been born from broad collaborations across nursing, patient safety, patient experience, frontline staff. Our guests and their teams have gathered stakeholder input from across the hospital, and they're really in the process now of a pilot study that tests a new intervention aimed at protecting patients in the bathrooms, but still not taking away dignity or independence. So it's a story about innovation at the bedside, balancing safety with humanity, and about creating solutions where sometimes it seems pretty tough. So, three leaders are helping us out today. They're bringing fresh ideas and bold action to this problem. Dr. Allyson Palmer is a consultant in hospital internal medicine, and she serves as a physician advisor for the Rochester Fall Injury Prevention Committee. We also have Amberly Hess, who is a clinical nurse specialist, holds her Doctor of Nursing practice, and co-chairs the Inpatient Fall Injury Prevention Committee. Also joining us today is Cari Guttormson, who is the nurse manager and co-chair of the Inpatient Falls Injury Prevention Committee and a member of the Safe Patient Handling and Mobility Subcommittee. Maybe we could just start by me asking each of them to tell us a little about themselves. Dr. Palmer, can you just tell us a little bit about yourself? How did you come to Mayo Clinic? What's your prior experiences, and how did you get involved in this work?
Sure. I'm originally from Ohio. I came to Mayo Clinic as a medical student long ago, and currently am working as a geriatrician, hospitalist. So you'll find me on the geriatrics consult service most of the time. And of course, as a geriatrician, falls are a geriatric syndrome. And so I'm very interested in preventing them. And so that is what led me to the work with the Inpatient Fall Prevention Committee.
Fantastic. So we're so glad to have you here. Amberly Hess, can you just tell us the same? How long have you been with us at Mayo, and what's your journey been like?
Thank you so much for inviting me here today. I have been here at Mayo for a little over 6 years now. As a clinical nurse specialist, our job is to be detectives, and we take a look at things that could get in the way of excellent nursing care and things that might have a negative impact on the patients. And those nurse-driven quality indicators, falls is one of the highest. So I have always been passionate about keeping our patients safe and helping to prevent falls. This was just a natural fit.
Well, you have a lot of courage. This has always been a very tough problem for every hospital everywhere. So thank you for that. And Cari, how about yourself? Tell us about you.
Good morning. So I am originally from Florida. That's where I started my nursing career. I've moved quite a few states in that time frame. Came here from Washington State just a little over a year ago. I was leadership out there for Hospital Association out there and came to Mayo wanting to do bigger and better things. I have vast experience in falls working with the neurology patient population in Washington. And so when presented with the opportunity a couple months ago, I jumped in full force. Falls is kind of my passion, keeping patients safe, and currently a nurse manager on a pulmonary unit. So we do have higher fall risks.
You three are from a lot of different backgrounds. I'm just actually sitting here thinking, how did the three of you meet? Was it somebody called a committee together and there you met each other? Or how did you come together, if you can recall that for us?
I first met Dr. Palmer, Allyson, when I was trying to understand how to help post-op delirium patients, a post-op ortho unit. And then we met up again when we both joined the Inpatient Falls Committee. It's just been a wonderful collaboration.
That's right, Amberly. I forgot about that. I think our passions brought us together even before the Falls Committee.
I think so.
And Cari, how about you? When did you get linked up with these two?
I actually got linked up with them when I joined the injury prevention subcommittee. And it's been such a great experience working with them both. The passion and drive behind all three of us just to get things done and really help keep our patients safe has been amazing.
I'm always interested in learning how teams get together. So thanks for sharing that with us, because I think it kind of speaks to the issue of shared passion, but also shared work and sometimes just the coincidence of things, isn't it? But thanks so much for doing that. So sounds like today we're going to focus on maybe one particular aspect of this, and that is looking into sort of that particular space of falls on the way to, in, and around toileting activities and bathroom activities. So how did you all first get interested in this particular problem? How did you begin to envision how you deal with it? How did you get started on this problem? Cari, do you want to start?
Yeah, I can definitely. So oddly enough, we were doing root cause analysis meetings on quite a few different units at various times, and we noticed a theme that our current initiative for what we call WAR is not effective, and it wasn't really being communicated from staff to us that they were really receiving what the actual message was. We would hear different topics of, oh, I thought it meant that I needed to remain with the patient at all times, or I thought it meant that their belongings needed to stay within arm's reach. And nobody really had that clear message of being within arm's reach in the bathroom, which is what that initiative was originally intended for.
So that's what WAR stands for, within arm's reach.
Yes.
Okay, gotcha.
And so we really decided to kind of take a look at that and how do we need to fix this? How can we really drive home that message of staying with the patient in the bathroom is so important to keep them safe, but make that message clear for staff. And so that's really kind of where the stay with me idea started to form.
Wow. So you came up with this idea probably in a committee meeting, talking with one another. Who did you involve as you started to organize this more extensive work, and why? Maybe Amberly, you want to tell us about that?
We were taking a look at the data as a clinical nurse specialist. That's what I do. And we were all aghast at the fact that at least half our falls happen because of bathroom related activities. And we decided that we were no longer going to go along with the fallacy of sunk costs. We were going to innovate. We were going to start over. And so we reached out to our enterprise colleagues. We reached out to the practice chairs here within Rochester, and we brainstormed amongst ourselves as subject matter experts to try to make it clear and easy for the staff to understand which patients need to have people accompanying them in the bathroom. And the simpler and more clear and explicit we can be, I think the better we're going to have results.
So you start to get together and then you look at the data, and the data tell you, hey, the biggest proportion of problems are in the bathroom. Then you understand that there's some lack of clarity about what behaviors should actually be happening to try to reduce these falls. Dr. Palmer, what were some of the real big challenges with starting to work on that particular problem?
Yeah, I think Amberly just hit the nail on the head about communication. So we've realized through discussions with key stakeholders, which on the patient safety committee and our quality committees, we have representatives who are bringing the patient voice to the conversation. And that, I think, was one of the things that really made the light bulb go off for us, that we have been going over this message over and over that the bathroom is the place that's dangerous for falls, but we haven't told the key stakeholders, so the bedside nurse and the patient, why this is important to do. Because as you mentioned at the beginning, going into the bathroom with somebody is uncomfortable. Having somebody come into the bathroom with you is very uncomfortable. And so we needed to address why we're doing these interventions. And so part of the strategy that we are forming is improving our communication to the patient at the outset of the hospitalization, explaining why the hospital environment is high risk for falling and helping them to understand their unique risks based on their medical comorbidities, their history, but also the risks that the hospital environment poses that are outside of the patient's control, the unfamiliar environment.
Yeah, Dr. Palmer, you mentioned you're a geriatrician or gerontologist, and so, a lot of your patient population I guess we could expect might be elderly, and they have their own problems. How does that conversation go with them? What's been your experience or the experience of your group when you start having a conversation and you explain to Betty, who's a farm wife from the middle of Iowa, that, we want to accompany you into the bathroom? Tell us how that goes.
Yeah, I think it really starts with that conversation about the individualized risks of falling that a patient has. We don't realize that as we age, physical things change, yes, but also medications affect us differently. Our behaviors affect us differently. If there's any cognitive impairment in the picture, that's a huge factor that can lead to falling. And so it's really focusing on those individual risks with the patient and letting them know anybody can fall in the hospital. And also, you have increased risk because of XYZ medical condition or medication that you're on. The things that we're doing in the hospital sometimes increase that risk. And so I think getting to that level of really understanding we're trying to keep you safe because of these risks. The worst thing that could happen is that you get injured in the hospital, and we're trying to prevent that. I think if we come from that angle, a lot of times we get more buy-in from everybody.
Yeah, I know as a physician, when I've worked in the hospital or even as outpatient, when you're trying to convince somebody to change their behavior or accept some new circumstances, that, a lot of times I think their fallback is, well, that's not how I do things at home. And I always have to remind them, yes, when you're at home, you're not sick enough to be in the hospital. I mean, this is an acute change, a different environment. But, I'm also reflecting back when I was patient safety officer. To me, an unusual number of falls occurred, and often in the bathroom, in people who were not elderly. I just want to explore what the issues are here, because I know very often we all are uncomfortable with saying, hey, we want to accompany you to the bathroom, or let me help you with that. What's that go like?
Well, Dr. Morgenthaler, that's a great question. One of the big issues that we have been addressing, both with our safe patient handling champions, as well as trying to create some scripting for all of our staff, is around resistance. We, as social people, we want to respect where people feel uncomfortable. And so our staff feels resistant to accompanying people into the bathroom, and the patients are resistant to having us in there. And so, one of the most important things is to utilize motivational interviewing techniques and to be emotionally aware and to call out the resistance without letting it remain unspoken. Because once we've acknowledged that we feel there is discomfort here, then we can start working in order to maintain everybody's safety.
How exactly would that conversation go? Can anyone give me an example of how we use the motivational interviewing techniques? I'm just, for our listeners especially, how does that happen? How would that conversation sound like?
Well, the first thing is that, especially with motivational interviewing, is that you want to identify where the patient, for instance, is emotionally invested. Are they emotionally invested in getting back home to their flower bed? Are they emotionally invested in walking out of the hospital so that they can see their daughter graduate? So you find where they're emotionally invested, and you help them to understand that they can achieve their goals best by doing the safe or the best practices by the allowing people to accompany them.
Gotcha. As you've engaged in these efforts, what have been the surprises along the way?
I think the biggest surprise for us was when we were investigating the without arm's reach, that there was no clear-cut definition of who should be and who should not be. There was suggestions and guidelines, but we really needed to hone down how can we present this to the staff that are at the bedside with the patient to help clearly identify who's going to be needing to be stayed with in the bathroom and who's going to be safe being in the bathroom on their own. And so that's kind of where we really started at first, trying to narrow down those individual processes of who should be and who should not be. And I think that was probably the biggest challenge at first for all of us, was trying to figure out how complex do we make this? Clearly, if you're sitting down looking at all the data, you could make it a laundry list of ideas of who should and who should not, but we really needed to narrow it down. And I think that was the first biggest struggle that we had, was narrowing down that identification.
Hmm. So, in other words, so that you could tell clearly which patient really should and which patient doesn't need to have assistance to go in the bathroom according to risk factors and so forth. How do we identify that? Do we have a risk calculator, or do we have AI working on that, or what's our current status?
So we have a set of questions that are presented to the staff that they can answer. So it's, are they alert and oriented? Have they been identified with a high Hester-Davis score are they confused?
Are they impulsive? Do they use their call light appropriately, or do they kind of lurch up to get to the bathroom?
Do they have orthostatic hypotension? Are they within 12 hours of post-op anesthesia? We have a concise list of inclusion and exclusion criteria.
I see. So currently it's a checklist or a scoring list where if you have these, then you're at the higher risk. Just out of curiosity, you're still piloting this and refining. Are you already thinking about ways to use our EHR to bring up, hey, this is a person that's at risk, so that we don't have to go through the checklist? Is that something you're starting to talk about, or not yet? Or where I'm overly curious, probably.
At the moment, what we are looking at is human-centric nurse judgment. This is an assessment. We can use the EHR after we have it built into our flow sheets to help pull some of the data, like what the Hester-Davis fall score was or what the BMAT, bedside mobility assessment tool score was, so that the nurse doesn't have to double document. But at the end of the day, what it comes down to is critical thinking and human nurse judgment, saying this patient is or is not a fall risk. And then we can use the EHR to alert everybody that you need to stay in the bathroom with this patient.
Okay. Well,
There's certainly a lot of interest in using automated technology, artificial intelligence to help us here. And those efforts are kind of continuing in the background to see if there are tools that could help us, both in terms of ambient technologies. Is there a way that some technology could help us alert farther in advance than a chair or bed alarm that a patient's about to fall and give us a couple more seconds to get in the room to help them? Are there ways that we could use our existing data to determine who is at a high fall risk? And so those efforts are kind of ongoing. The difficulty is that, again, that individualized risk, it's difficult to capture that sometimes in a generalized score. Although those efforts are ongoing, it's been very challenging.
yeah, I imagine so. So, what's the current state of the project that you're undergoing right now? Where are we at?
So we have recruited units to participate in the pilot, and we are about to go live. So we are very excited to start collecting data and hopefully see that we're having an impact.
Is based on the number of falls per hospital day or per week or something. How long do you anticipate you'll need to collect data before you can make a conclusion? Are we talking about 3 months, 6 months, 12 months? What's the anticipated pilot duration?
We suspect that after 3 months, we'll have more than enough data, unfortunately. We have very sick patients who come to us looking for help, and that leads to having high fall risk. So we plan to run our initial pilot and collect data through the end of November. And at that time, we will evaluate where we're at.
I think that's just awesome that you've taken the time to figure that out, because I think that a real risk in quality work in general are, we have lots of motivated, brilliant people thinking of things to try. And then I think discipline requires that you say, okay, how long will we try before we say this was a success or a failure? So good on you guys. So what do you think will be the impact on our patients, and maybe more particular, because I think the simple answer is we're hoping this reduces their risk of fall, but what other effects or impacts do you think this will have on patients and staff at Mayo Clinic?
Well, I'm hoping our approach that emphasizes communication will make patients feel more part of the conversation about their care and provide that connection with their bedside staff and their team in the conversation about keeping them safe.
And I suspect that the staff, sometimes they experience frustration when we give them an intervention that is not entirely clear or possibly even entirely useful for them. And aside from frustration, they can start to feel some moral distress because they want to keep their patients safe and healthy and happy. So I think that this is going to result in improved morale, quite frankly, for the staff as well.
Awesome. Cari, what are the next steps of this group? You're keeping track of everything here. You're the nurse link to all this. What do you think is next in this pilot project and the overall scheme?
My hope is that once we have the data that we have, that it clearly identifies that this is definitely the direction that we go, and we can eventually work on expanding from just a pilot to hopefully moving throughout all of Rochester and improve our rates that much more to keep our patients even more safe than we currently do.
We're planning to have weekly touch points with the teams who are working on this with us so that we can iterate as we go, see what the pain points might be, and improve it even during the pilot.
Fantastic. So what concerns, or do you guys have worries or concerns about this pilot project?
The only concern that I have been made aware of is that this is not the only project in order to improve patient safety that's happening throughout the hospital. So we simply need to keep the staff motivated and involved. We need to continue to have their buy-in so that we can present the best possible chance for Stay With Me to succeed.
Many of our listeners are, from hospitals of varying sizes, some larger than St. Mary's and some quite a lot smaller. And I imagine all of them, since, as we mentioned at the very beginning of this podcast, patient falls has been a problem in hospitals since we started measuring it and before that. But what would you say to an organization that's saying, yeah, that is what happens. They fall in the bathroom. What would you say should their first steps be?
I would say that their first step should not be to assume that they know what the answer is. I would say that they should keep an open mind and that they should closely question both the literature and their frontline staff.
Well, I just want to express gratitude to the three of you for, first of all, being so generous and sharing your time with us today and engaging in this conversation. I also want to thank you on behalf of our patients that your work is really contributing to their safety and that your heart and actions and intellects are in this, and it's really clear to see that you're feeling and thinking and working together. And thank you for bringing together the teams that are working on this. And finally, thank you for actually the way you're motivating our coworkers, because I think you're right. I think when everybody comes to work, we all want to do the right thing, and sometimes we need somebody to help us figure out how to do the right thing. So thank you so much for that. Thank you for being with us today.
Thank you for having us.
Thank you, Dr. Morgenthaler.
Thanks for having us.
This has been really good. So we've come to the end of our podcast, and we're glad that you could join us. We hope the information has been insightful and valuable. Remember, Mayo Clinic's Key into Quality podcast aims to highlight some first steps in addressing important quality challenges in your organization. Our goal is to improve quality for patients and the populations that we all serve. Thanks for listening. Follow, rate, or share Key into Quality and help us spread the word. Until next time, goodbye.